Good afternoon, everyone. I'm Hyeon-Cheol Gwon from South Medical Center. I'm co-chairing this session with the legendary Dr. Spence King, third. And this session is live case and lecture 6, complex PCI. We have a lot of big names in the panelists: Dr. Chee Dr. Kefei, Dr. Fukuhara, Dr. Jung, Dr. David Kandzari, and Dr. Yongcheol Kim, Dr. Jinbei Lee, Dr. Michael Lee, and Dr. Sunao Nakamura, and Dr. Ping-Tim Tsui. And we have a live demonstration from Fuwai Hospital, China, case number 9. The Fuwai Hospital? Yeah, I'm Hyeon-Cheol Gwon. So, good morning, good afternoon. So, can you introduce yourself and your case today?
Okay, thank you. Good afternoon. Dear moderator and panelist and everyone. I'm Dr. Yim from Fuwai Hospital in Beijing and China. It's my great honor to participate in TCTAP.
Dr. Yin and Dr. Gao, it's great to see you.
This is Dr. Gao, a senior investigator cardiologist. He and I will do this case together. And Dr. Hu, interventional fellow. And we have 2 nurses, Ms. Dong, Ms. Jia, and technician, Mr. Chang. Okay, I will invite Dr. Gao to present the case overview.
Okay, thank you for introduction. I'm Dr. Gao from Fuwai Hospital, and let me first provide a brief overview of this live case. And please switch the screen. Okay. This live case is a 68-year-old man who referred to our department for recurrent chest pain for 3 years and worsened in the past 1 month. And he underwent angiography for about 3 weeks ago. And the previous angiography demonstrated 3 vital disease and RCA CTO lesion and a borderline stenosis in proximal to mid LAD, and with severe calcification, and about 90% stenosis in proximal segment of circumflex. And this patient has no history of myocardial infarction, previous PCI or CABG. He was diagnosed with pulmonary fibrosis for 2 years. And next page. Next page, please. And this patient has several cardiovascular risk factors, including diabetes, hyperlipidemia, a smoking history, and a family history of cardio heart disease. And his clinical presentation can be summarized as unstable angina or increasing angina. Next page, please. And based on the result of echocardiography, the cardiac function was normal without regional wall movement or disorder, valvular disease, or pulmonary hypertension. And as was mentioned before, the previous angiography demonstrated CTO lesion in distal segment of RCA and borderline lesion in proximal to mid LAD with severe calcification. About 90% stenosis in proximal segment or circumflex with bifurcation involved. Next page, please. And these are the relevant images of the previous angiography. And the RCA was occluded in the region adjacent the second band of RCA. And we can see the borderline about 70% stenosis from the proximal to mid segment of LAD with severe calcification and about 90% of stenosis in proximal circumflex. The next page. And the primary target lesion in this procedure is RCA CTO, and maybe we should estimate the significance of the lesion in LAD, especially when we plan to start the retrograde approach. The adjunctive medicine medication includes dual antiplatelet therapy and starting nitrates and hairpin before the procedure. Next page. For this lab case, we have predefined 3 questions to discuss. Based on the previous angiography, how should we formulate the interventional strategy for RCA CTO PCI? Second, when and how to switch high-priority CTO PCI strategies. And in consider of the borderline lesion in LAD, during retrograde CTO PCI, it is mandatory to evaluate the functional impact of LAD lesion prior to intervention. Thank you very much.
Okay, thank you, Dr. Gao. Today we perform the angiography again, so I will show you the angiography. It is consistent with the imaging of local hospital. You can see next. You can see the borderline and the borderline lesion in LAD and with the severe calcification. And the next, please. And a severe lesion in the circumflex and the next, and CTO in the RCA. So, as Dr. Gao explained, this CTO is unclear proximal cap and a relative long CTO segment. So we need to prepare the retrograde PCR back. But there is a very nice septal channel. But as we mentioned, there is a borderline lesion at the LAD. So when do the retrograde PCR, we will consider the LAD ischemia. Maybe we need to do procedure hours LAD evaluation, and maybe we need the LAD PCR in advance. We would appreciate the panelist guidance about this matter. And additional, if we do the retrograde PCR, we can see the CTO distal cap at the bifurcation of the PL and PD branch. When the retrograde wire come from the PDA, the distal cap puncture will be some difficulty. So maybe we can use another branch from the septal, which connected to the PL. That maybe improve the directional puncture of distal cap. So before initiate the CTO PCR, we performed the LAD hours and the QF. Then show me the hours, please hours. Next.
This IVUS is from for LAD?
Yeah.
Okay.
From LAD distal part. The distal part is almost normal. The vessel about 30 millimeter. And
so
as
you're
the iris pull back, we can see some calcification plaque. Here. And we will go to the most severe site here. Yeah. And the calcification almost 270 degree about.
So
Please
you're
go back to
investigating
MLA site.
You're investigating this LAD so that you have the ability to do retrograde approach to the right if you need it. Is that the way I'm understanding it?
Yeah.
And will you try to do antegrade approach to the right first?
Yeah, of course.
Yeah.
But it's all only the backup plan.
So
backup plan.
I'm sure one question
The
that arises.
MLA is about 2 to 2.2 millimeter square, and the plaque burden almost 80%. And we also perform a QFR, angio FFR, show the QFR.
But if you are considering the retrograde approach, if you stand the LED first, there is some maybe more complex to the procedure through the stent struts. Have you considered that?
Yes, so I want some guidance from your guys. The QFI is also positive, 0.73. But I reviewed the hours carefully. The septal is take off from proximal to the most severe site. Maybe if we need a retrograde PCR, we can try. If there's no septum or something, we can perform the RCA-CTO PCR first, I think.
So actually, this patient presented as unstable angina. What lesion is the culprit of unstable nature of the presentation? I think circumflex is the most important culprit for that. So if I were the operator, I try circumflex first and let the LED, the inside to leave the LED for the future and retrograde approach.
Yeah, would you explain to us that you're not going to approach the most straightforward lesion, which seems to be a very high-grade lesion of the circumflex? What is your thinking about that?
Because let me show you back. There's some retrograde, from circumflex, there's an epicardial channel to supply the distal supply for the RCA. So I think maybe some danger, high risk for first to do the circumflex PCR. So I want to do the RCA-CTO first.
Dr. Nakamura, you are expert in CTO PCI, so do you prefer to treat the LED first or just go ahead to...
So just about the circumflex, we have some collateral to the RCA. So a little bit, maybe I think this is compromised. Maybe better to do the later circumflex. We have some
LED
collateral. LED, of course, this is the indication of the PCI, but maybe antegrade. Antegrade, 99% success. If you mix retrograde, 200% success.
So can you see the dual injection is the LAD and the RCA?
Yeah, we have a very beautiful collateral.
The dual angiogram give us a surprise. You can see there's some microchannel from in the RCA-CTO. So I think the integrated CTO PCR is promising, I think. So I will do the RCA-CTO first and next the LAD.
I'd like to make it clear that FFR less than 0.8 does not indicate that this lesion is ischemic. We all know is that above the 0.8 is the non-ischemic. Under 0.8, there is some possibility that this lesion can be ischemic. So I like to leave the lesion LAD alone, actually. So
the LAD QFI is 0.73.
73. It does not necessarily mean that this is ischemic when this patient exercises routinely. Anyway,
Well, usually a couple of things. One is that the LAD is the donor vessel, so it's not uncommon to maybe see a borderline threshold because the LAD is providing a greater territory than the LAD itself. But usually that delta in the FFR, for instance, is about 0.05, so it's not as dramatic as we might think it would be. I think hemodynamic assessment of the LED is reasonable as you're doing, but in most instances, I think we would treat the circumflex and the LED first, just thinking about contrast utilization and fluoroscopy time and enhancing collaterals to the right. The challenges for the LED, as you've mentioned, you'd be stenting across a septal that you're going to need for a retrograde approach if needed. But really, it's the distal posterior laterals that are the big target here more than the PDA itself. And it's a pretty short total occlusion here, so I think you should be able to get this integrate.
Actually, I do not have many experience of the angio-FFR, but is it reliable value of the angio-FFR in this patient with RAD give the collateral flow to the RCA? Is we believe the FFR value, angio-FFR value is 0.73?
So we don't know. Actually, anyway, you are already start at I think it's enough discussion about the strategy, which one first and which one should be treated or not. And we have spent 16 minutes now, and we focus on more about the procedure itself. So what's the progress until now?
This is my first detail guide wire. It's built XDR. If it can advance further, I will escalate it to the maybe area again first.
Now, what's the name of the microcatheter here?
Yes, it's Cosel Pro.
Cosel Pro.
Yes.
And interestingly, you used another wire coming out from the AL1 guiding catheter in RCA, going to the aorta, maybe it's to prevent deep engagement of a guiding catheter. Is that right?
Yes. You
use it routinely?
No. Because when the guiding engage, the BP depression, there's some stump. So I use a floating wire to protect the ostium of the RCA.
So guiding catheter is a 7 French, each one?
7 French and plus 0.75.
0.75, AL1,
Yes.
AL 0.75, okay.
Yes.
And the guide wire is, which guide wire is this?
XTR, taper?
Yes, XTR.
Okay. So there's very little filling of that segment of the right coronary artery. It looks it's either just completely underfilled or it's severely diseased. I don't know which at this point.
Diffusely diseased. The very small target we have. Actually, when I use AL1 or AL 0.75, we have a lot of dissection in the entry site of RCA. So, 7 French is the usual practice for this lesion, Dr. Nakamura? 7 French, 6 French, which one do you prefer?
So, in this 20 years, I just use the 7 French.
7 French is better.
Because we can use, 2 parallel technique.
Yeah, body
So
wide
actually,
technique.
his technique is okay.
Okay.
Wiring and advancing the corsia is very soft. This is okay, very nice.
UB3?
The XTR, I think, is in subintimal. I will upgrade to the medium stiffness guide wire. I prefer the UB3.
How do you confirm this is subintimal? Looks like on the way.
Is it because the wire won't advance, or because the tip doesn't turn, or what is the clue to knowing it's subintimal?
Both. The wires cannot go relay to the distal part, and we confirm use the retro retrograde angiogram to the wire does not in the lumen, I think.
So the class question, which wire first? What do you prefer? Any doctors can recommend. Actually, for me, the UB3 is the first wire to attack this kind of lesion because the tactile feedback is great. In tapered wire, sometimes we can feel that even if it wire go into the subintimal. Any other comments about the first choice of the guide wire, this kind of integrated approach?
Maybe this is a doctor's preference.
Doctor's favor.
Yeah.
But you will have your own principle how to select the guide wire, the lesion by lesion.
No principle. Field C, Gaia next to first, second, third.
Oh,
May I ask Dr. Werner? God of the PCI, yes.
okay.
I think a lot of us would start with the Pilot 200 as well, but I think regardless of the wire, what's happening now is we're getting intramural hematoma and you're losing all that visualization. So it's getting to a point of thinking about retrograde or making this a dissection reentry kind of investment procedure, perhaps.
Yeah, it's not
Wires
very
looks
easy.
in the subintimal space.
It seems like at the very beginning, the wire got into the subintimal. I think you need to adjust the direction.
Okay. I pull back the wire and looking for the entry point at the beginning. 慢一点，等一下。
Although it looks like a patent, it's subtotal based on bilateral injection, but sometimes anti-grid wiring is also very difficult. So I think if the wire is in subintimal, and I think subintimal space is getting bigger and bigger, so now switch to retrograde is another option.
这是影响。
In this electricity lesion, there is a small channel, so I think more small angle, pedestal tip angle will be more better to reduce subintimal widening. Your tip angle is too large, I think.
With the use of microcatheters these days, it's a question for anybody, is it often happen that the microcatheter, if you get a dissection and if you get subintimal, does the microcatheter cause you a little problem by putting you beyond the entry point already, and so it make it more difficult to find the true lumen at a proximal point?
Yeah, yes, but actually previously we can see the 100% root. So after wiring, just put inside and then advance in the course a bit more, and then maybe better to not do the antegrade and injection. Maybe just using a retrograde injection. Maybe I think getting a little bit bigger.
I think it's not very easy for integrator. So I will switch to the retrograde.
Yeah,
okay?
I think there are several options in the body wire technique over CISO and the reentry, integrated reentry, and retrograde approach. So integrated reentry is not so popular in Japan, right?
1.5的。
Integrated reentry, like
We have many doctors using many
But
techniques.
the
Yeah, using actually many doctors using many techniques. But maybe I think most of the doctors want to do just integrate.
just integrated. Then it fails Then other option is reentry or retrograde.
In this kind of case, maybe we don't use that kind of technique.
Yeah,
Just integrate or just retrograde wiring,
right.
and we can make it this marker.
Because distal runoff is not
Very good.
with a large lumen. This is diffusely disease. The antegrade reentry is not candidate for distillation. Dr. Gao, you are preparing the retrograde, or what your strategy now?
Yeah, I prepared to the retrograde.
Okay.
So of course, retrograde approach is one option in this situation, but in Japan, IBUS guidance, ADR is
Reentry,
one
yeah,
option.
yeah.
So we can use the anti-all system, so we can look and confirm the direction of the true lumen and puncture.
In that purpose, actually, do we need 8 French guiding catheter or 7 French?
Yeah, 8 French is
8 French.
good, but we can use 7 French system with like smaller profile microcaster, like fine cross or something.
Actually, these days, the
Yes, now this one.
strategy change is much quicker than before. In the in Japanese CTO live demonstration, they took about 2 hours or 3 hours procedure, but recently it can change very quickly and escalate the wire, escalate the strategy.
Usually, don't use more than 1 hour.
Oh. One of the quickest strategy changer.
Because of the collateral perfect, and then together we can see the whole root, so we can do anything. Usually.
Here's the chip injection.
Yeah.
It will the continuous and moderate pulses channel.
Very
I
large.
use the Tsui 03 wire.
Lots of wires.
Tsui 03.
So 03. That's collateral is big, but there are a lot of branches.
Yeah.
Yes.
I think this branch ultimately train to the PLA. Maybe it can improve our retrograde puncture.
Yes.
Yeah, very quick.
就在这就行了。confirm 一下，嘛也可以。Will confirm the wire. I think it's okay. Okay. 但是远端的攻击段好像不太准。
哦，还可以吗？
只做45。
Okay. Now we can see that the integrated wire is subintimal, definitely.
Yes,
Yeah.
yes. At the very beginning.
FCR?
有不舒服吗？你有不舒服吗？会有点，因为我们从反向给你做
Maybe here, and there is a very short occluded path.
And need
So I don't
another
think
FCR.
SUO3 will cross here.
FCR.
再来一个。
Another. STR.
So another suggestion is I think you should pull UB3 a little bit back. You can see it's go further and maybe make a subintimal space bigger and more distal.
Okay. Oh, 有一个。
10 minutes.
So I hope the retrograde wire can directly cross to the proximal cap and to the proximal normal vessel. If it can't go through, I need to manipulate the integrate wire as the retrograde wire as a marker.
Now is the wire is Sion or
No, it's
XDR.
XDR.
XTR
XDR.
retrograde?
Yes. I pull back.
For
the
this patient, I
integrated
think
marker system.
Dr. Yindong select a right collateral because several collateral connected to distal RCA, but this one is first getting to the PRA. And then it's easy, the attack angle is good, so it's easily getting to the cross the odd lesion.
Yes, sir.
Can I ask which microcatheter are you using for retrograde approach now? There is two markings, so there is non-usual microcatheter, I think.
Yeah, it's a domestic microcatheter. It's like a fun cross, but it's a little bit thin. It's 1.7 French, and it's I think much softer and thinner.
Be careful, maybe I think the retrograde wire is not in the right place. Maybe change the direction.
Yes. Maybe we have two options. First, we can change the wire, or maybe we can use integrator arrows to check the retrograde wire.
Why don't you use IVUS for antegrade? I mean, we can see the wire position in the middle version of RCA.
那个symbol 给我一个。
I think one way or the other, though, you're going to have to change out to a different retrograde wire.
Yeah.
Yeah.
I think pull the microcatheter a little bit back and redirection the retrograde wire.
Or just an angiogram from the RCA?
But I'm afraid the integrated there's some hematoma, so I want to do many angiogram.
Well, we can't see the angio now. We can see only iris
Yeah,
image.
fluoroscopy, please.
Switch the arrows to the angiography.
有一个盖一。
Yeah, first.
So you want to use antegrade wire to puncture the retrograde wire, to do the wire kissing?
No, I
Retrograde.
wanted to retrograde aspiration.
Okay. So my suggestion is pull a little bit back at the microcatheter, maybe too close to the short CTO.
Okay.
So in this situation, the antegrade guide wire was already inserted enough, so reverse cart is the most easily way to make the connection.
yes, it's the next choice, I think.
This one is good.
Roof.
Yeah.
Oh, great. You need a angiography now? Actually, I had to say that you have 5 minutes. I'm afraid.
Okay, yeah. Anti. I think it's okay.
It's okay. Just push,
Yeah.
push.
Okay, okay, great.
Thank you. So I need a.
Or the retrograde microcatheter?
I think
Yeah,
to push
I,
microcatheter up to the middle RCA and change a
Yeah.
workhorse wire, it's easy
Yeah.
to get into the antegrade guiding.
Yeah.
I think it will be easy to push the microcatheter.
Another technique is to give the guide extension from the RCA to the midpoint of RCA. So easier to...
Yeah, the retrograde microcatheter is already in the middle part of the artery. So I can change the workhorse wire, try to
Okay.
insert into the unplus. And we can do the externalization. And during the retrograde piece, I asked the patient, she denied the symptoms. So I think now it's okay. There's no ischemia of LA.
So is there any reason to keep the anterograde wire at this moment?
A good suggestion. I think you can pull the antegrade UB3 out.
Yeah, but I need a workhorse for stabilize the antegrade catheter.
If your guide catheter was deep-seated, this may be the time to take out that
Yeah.
wire in the aorta and
Yeah,
take advantage.
I think so. I think so.
There you
I
go.
think so. Thank you.
Good work.
Yeah.
Okay.
Okay. Thank you.
And you will do the T-pin technique or RG3?
Usually I like the tipping. Yeah. I pull back the antegrade microcatheter in the antegrade catheter, and I want to insert the retrograde wire to the microcatheter. No.
So you're successfully making this wire connection. We're going to need to move to the lecture, but we can come back. Can we come back to see the results here? A few minutes?
I'm not sure.
We're not sure. We'll try. If we can maintain the connection,
Yeah.
we will try to come back and pick up on there.
Okay,
Yeah,
thank
you
you.
have 1 minute, so can you summarize your procedure? This is quite great work.
Okay, thank you. I think it's multi-vessel disease. So I think we need a pre-evaluation for each vessels and make the good plan and the backup plan. A little bit. Okay.
A little microcatheter pull back will be better.
Sometimes guide extension is much easier.
Using great coverage. Okay.
So if it's
Usually-
difficult, you can push the retrograde medical catheter to the antegrade guide.
Yeah.
And
Usually
the-
it's not
Okay.
very difficult.
Yeah, but
tipping, usually it's easy, but
Yeah.
Okay, well, we'll move on now and hear the lecture, which is going to be by Dr. Sripal of Bangalore. Once again, he's going to talk to us about the management of calcified coronary disease, rotational atherectomy, and/or orbital atherectomy.
Thank you very much. And that was an interesting case. I'm sure if we can go back later, hopefully they'll be done. These are some of my disclosures as it relates to this particular talk. And as we saw in the prior angiogram, calcified coronary artery are pretty common. I mean, depending on the definition, if you look at angiographic calcification, it's seen in nearly a third of the patients. And if you use intravascular imaging, it's seen in a lot more of the patients. And clearly, we know from a ton of data that severe calcified lesions have short-term and long-term prognostic implications. In terms of short-term, there is increase in safety risk. There are greater risk of procedural complications, including major dissection and artery perforations. It impedes stent deliverability and also prevents stent expansion. In fact, intravascular imaging studies have shown that the greater the arc, length, or thickness of calcium, the greater the likelihood of stent under expansion. And the impact of severe calcified lesion is not only related to short-term outcomes, but multiple observational studies have shown a significant long-term impact of severely calcified lesion. Here is a pooled analysis from the Horizon and Acuity study looking at no to mild calcification, moderate calcification, and severe calcification. And as can be seen here, the greater the amount of calcification, worse is the prognosis, increase in death, MI, target lesion revascularization, and also MACE. So what can we do about calcified coronaries, and what is our approach? As can be seen on the slide, there are a number of published calcium algorithms. I mean, you can multiply this by many folds. I mean, there are that many calcium algorithms. I was part of the SKY expert consensus statement on the management of calcified coronary lesions. So I'll take you quickly through this process, and we'll, at the end of this, apply to one of the cases. So this is the SKY expert consensus algorithm. So if you have angiographic evidence of calcified coronary lesion, the first thing that we recommend is intravascular imaging to evaluate criteria for calcium modification. And the criteria for calcium modification includes a 360-degree arc of calcification, or if you have a greater than 270-degree arc of calcium and greater than 5 millimeter length of calcium. Additional characteristics to consider are calcified nodule, or if you have a minimal thickness of calcium, which is greater than 0.5 millimeters. So if you do intravascular imaging, and if you have intravascular imaging criteria met, you can consider atherectomy, intravascular lithotripsy, or specialty balloons such as OPN. And the consideration how to choose between atherectomy, IVL, or specialty balloons depends on whether the lesion is long diffuse calcification with or without nodular calcification, which favors atherectomy, typically rotational atherectomy if you cannot cross the lesion. If it is concentric, eccentric, or nodular calcium, consider intravascular lithotripsy. Once you do calcium modification, the next step is to consider repeat intravascular imaging to see if there are calcium fractures. If you don't want to do that, the other potential option is to use a 1-to-1 size balloon and look for full expansion in 2 views. And if you do either of these two and you confirm good expansion or calcium fractures, you can proceed with PCI. If the answer is no, you go back and do further calcium modification. The other potential option is your intravascular imaging is not feasible, or you are not able to deliver intravascular imaging catheter, then you use a 1-to-1 sized balloon, try to expand that lesion. If the balloon is not deliverable, consider atherectomy, typically a front-cutting atherectomy such as rotational atherectomy. And once you're done with that, intravascular imaging or again, one-to-one size balloon to confirm that you can actually expand the lesion before proceeding with PCI. So we have a number of options to deal with calcium. In terms of atherectomy, you have rotational or orbital atherectomy. With rotational atherectomy, the burr spins concentrically on a wire. With orbital, it oscillates in an orbital pathway. With rotational atherectomy, the lumen size is similar to the burr size, so you will have to upsize your burr depending on the size of your artery. With orbital atherectomy, the lumen size depends on the speed of orbital atherectomy, the number of passes, and the time. Rotational atherectomy is front cutting. So if you have difficulty passing equipment, this would be the way to go. With orbital, it's circumferential cutting, so there is no blades in the tip of it. So this should be used if you can actually deliver some equipment across. What about intravascular lithotripsy? The technology is based on lithotripsy used for kidney stones. The extracorporeal lithotripsy uses very high pressure. So if you move away from that to intracorporeal lithotripsy, the pressure required is less. And if you use intravascular lithotripsy, the pressure is even less. And this kind of cartoon kind of shows how IVL cracks calcium in situ. There are emitters which creates expanding and collapsing vapor balloon, and it creates short bursts of sonic pressure waves, and the sonic pressure waves travels through the vessel with an effective pressure of around close to 50 atmospheres. And this localized field effect within the vessel fractures both superficial and deep calcification. There are a number of limitations of conventional calcium modification technique. If you look at balloon-based therapies, high-pressure balloons preferentially will expand away from the calcium. And because of this, there is predisposition to major dissection and perforation, mainly in the interface between calcium and healthy tissue, and something to be aware of. The limitation of atherectomy is, of course, you need dedicated wires. There is thermal injury, which can promote platelet activation, leading to increased risk of clotting. There is also distal embolization, slow or no reflow, and peri-procedural MI. When it comes to eccentric calcification, there is also limitation of balloon-based therapies, mainly to the extent that the balloon expands away from the calcium and there is a risk of dissection and perforation at the interface. If you look at atherectomy therapies for eccentric calcium, either the wire can be away from that eccentric calcification, and as such, it may have the atherectomy may have no impact, or you can create this guttering effect and not fully have that ablative therapy that you're looking for. IVL has been shown to have an impact not only on concentric calcification but also on eccentric calcification. Here you can see an example where you have eccentric calcification, and clearly you can see calcium fractures even in this case of eccentric calcification. So moving away from this, what are the overwhelming goals of calcium modification techniques? So I would say some of the goals are, we want to improve angiographic success. I mean, these are immediate efficacy outcomes. We also want to improve procedural success, which would be a combination of efficacy and your safety outcomes. And over the short and long term, we also want to improve clinical outcomes. And we'll see in the next few minutes or so, are there randomized trial data to support each of these goals for the use of calcium modification technique? I'll only discuss two trials which have been published this year. One is the roller coaster EPIC 22 trial. This was a trial of moderate or severe calcified lesions, 171 patients randomized to rotational atherectomy, IVL, or laser. And if you look at the procedural outcomes, angiographic success, procedural success, and clinical success, no significant difference among the three strategies, but laser at the lowest angiographic and procedural success, whereas IVL at the lowest rate of complications. The conclusion here was IVL was non-inferior to rotational atherectomy for stent expansion. Laser did not reach the non-inferiority margin compared with the rotational atherectomy. And there was no significant difference among the three groups for minimal stent area, but an obvious limitation of this particular trial is there was no balloon angioplasty only group. And it's important to recognize that OCT was used in 100% of these patients. Yeah, the other major trial, which was published this year, was the ECLIPSE trial. The intravascular imaging was used in 62% of patients, 2,000 patients, making it the largest randomized trial with severe calcification. Patients were randomized to balloon angioplasty versus orbital atherectomy. And as can be seen here, there was no significant difference in median stent area. Numerically, it was greater with orbital atherectomy, but there was no statistically significant difference. And if you look at clinical outcomes, surprisingly, there was, again, no significant difference between orbital atherectomy and balloon angioplasty alone for target vessel failure. So the conclusion here was these data support a balloon-first approach for most calcified coronary lesions that can be crossed, and I think this is critically important. This is applicable to lesions that can be crossed and dilated before stent implantation guided by intravascular imaging. So looking at these two data, let's look at all of the randomized trials to say, can we actually improve angiographic outcomes with the calcium modification technique? What about procedural success? This is a work in progress. We have looked at 13 randomized trials, 5,500 patients. This is a network meta-analysis of randomized trials comparing balloon angioplasty with laser, with IVL and rotational atherectomy. As can be seen here, rotational atherectomy, greater angiographic success, and if you rank these options, rotational atherectomy was ranked number 1, laser atherectomy was the worst. And if you look at procedural success, significant higher procedural success with IVL when compared to balloon angioplasty alone. IVL was ranked number 1 for procedural success, and again, laser was ranked the worst. What about, can we improve short and long-term clinical outcomes? I mean, ECLIPSE did not show that, and is ECLIPSE an outlier? Interestingly enough, what we have shown here is if you look at the endpoint of death, target vessel revascularization, no significant difference in terms of clinical outcomes. The same was true if you look at MI as an endpoint. There are a number of randomized trials. ISAR WAVE is one of them. Adnan Kastrati and his team are doing this trial comparing IVL with standard of care in patients with severely calcified lesions. Let's use this. Let's just look through one case example. 58-year-old male, recent end STEMI, heart failure, reduced EF, multiple risk factor, recent proximal circumflex stent, comes in for PCI of LAD. This is the angiogram, so you can see severe proximal LAD. Angiographically, it does not look that calcified. There are also branch vessel disease. Here we started with OCT, and clearly on the OCT, you can see long areas of concentric calcification, in many cases 360-degree calcification. So using co-registration, you can see clearly on the left side, the co-registration is mapping out where the calcium is. We did the rotational atherectomy, and I call this the precision rotational atherectomy because the co-registration is guiding you exactly where to do. I mean, you don't need to go back and forth the entire artery where many people do rotational atherectomy that way. This is precision exactly where those calcified lesions are. And then we went back based on the SKY algorithm with a 1-to-1 size balloon, and clearly with 1-to-1 size balloon, you can see there is a clear waste here. And we went back to our pre-PCI OCT. Clearly, you can see thick calcification, concentric calcification. This was a lesion which was not yielding. So we went with IVL, 60 pulses, again, co-registration based application of IVL exactly to the spot where we need to. 80 pulses. At this point, the patient was having chest pain. We took an angiogram. You can see the side branch is occluded. We rescued the side branch, diagonal stent and star and stent. We crushed the stent, and we used Coreflex 3.5 to further expand the proximal LAD. On a boost image, you can see a severe calcification there, but it expands. We ballooned the second diag, and we stented the LAD part, again, based on co-registration and OCT guidance, final kissing balloon inflation. We did a post-OCT run. And again, here it shows good apposition, but at the end of it, you can see some medial dissection. So we covered that, and this is the final results. So just to summarize, in terms of management of calcified coronary lesions, coronary calcification is prevalent and grossly underestimated by angiography alone. Sensitivity is improved with intravascular imaging, and this affects both short and long-term PCI outcomes, and intravascular imaging and appropriate characterization of calcification aids in appropriate pre-treatment. Whether atherectomy improves clinical outcomes need to be proven in randomized trials. Thank you for your attention.
Thank you, Dr. Bangalore. And for the nice lecture and the beautiful case. I'd like to close this session. Thank you very much.
Yeah, I'm interested in knowing really how you do select, because all those items are present. What are the features that take you to lithotripsy straight out, or when do you say rotational is better?
I'll take an initial answer. Is that I think deliverability of the IVL balloon is certainly an important limitation, and the length of the lesion as well. When we think about how many shock deliveries we're going to be providing over the length of the artery versus using atherectomy. For atherectomy, whether it's orbital or rotational, I think everybody has their own opinions about this, but certainly for highly angulated tortuous vessels, I think rotational atherectomy may be a bit safer because of the wire bias and the bias with the orbital atherectomy device. For myself, for larger caliber vessels like left main, I prefer orbital just because you get a greater excursion without having to use a larger guide for a larger burst size as well. So those are just some initial guidance features that might inform device selection.
Let me expand on that with anybody who wants to ask. What about balloon inflation? Even you see a lot of angiographic calcium. Maybe you see imaging shows not 360, but you see a lot of calcium. But do you start with a balloon to see if it yields at modest atmosphere pressure, and then go on with the atherectomy or lithotripsy, or do you jump straight to the atherectomy devices?
That's probably still more the art of medicine than the science right now. Certainly in Eclipse, we had criteria, fluoroscopic criteria, for instance, that would guide the interventionalist for equipoise, whether atherectomy or balloon angioplasty could be performed. Clearly, there are cases where it's unequivocal that you're going to need some type of ablative atherectomy therapy. Those are cases that were excluded from Eclipse. So these are cases going into it where there's an opportunity for either one. And Eclipse shows us that an initial conservative balloon strategy may be equally as effective.
Oh, we have time to finish. Okay. All right. I'm sorry that we didn't get a chance for everyone to wade in, and we have a case that we didn't quite get finished. But appreciate everyone being here on the panel, and thank you so much. We have to stop because we're over our time. Thank you.